Hi, my name is Dr. Thida Thant. I'm from the University of Colorado, and I'm super excited to introduce our session today called Breaking Down the Highs and Lows, a CL Psychiatrist's Guide to the Risk and Benefits of Cannabis Use. So no disclosures for me today. I also want to say, in case you're someone who watched my cannabis updates talk, don't worry. There'll be lots of new and exciting information from the other speakers today, so I don't want you to turn this off early. But I'm going to talk about what our learning objectives are. Basically, at the end of this, we're hoping that all of you will feel comfortable reviewing strategies to guide balanced and evidence-based discussion regarding risk and benefits of cannabis use with your patients. That two, you'll be able to discuss the evolving science and potential therapeutic benefits to cannabis. And three, feel like we've explored the impact of cannabis use in adults and other special populations such as youth and perinatal patients. So just an overview for today, I'm going to start with our introduction and also the adults in medical settings talk. I'll then hand it off to Dr. Denysenko for cannabis and headache and perinatal patients, followed by Dr. Laura Markley, who will talk about child and adolescents, and then we'll end with Dr. Helena Winston, who's going to focus on the potential therapeutic benefits of cannabis. So I think if you're here watching this recording, you already know this. Why does this topic matter? But I always like to highlight that cannabis is, one, a controversial topic, two, a rapidly evolving topic, and three, has a lot of implications for us as mental health professionals. And then lastly, look at this. If you look at this guide or this graph, you can see that use has spiked over the last few years and continues to rise. And so really the odds of you encountering a patient who has cannabis use as part of that picture is really high. The other reason this is an important and controversial topic is the mixed messaging. And so our patients often receive things like this on the left, right? There's just like tons of cannabis products out there. It's seen as a health kind of trend, a health intervention, but simultaneously, many of you may have actually gotten pretty like black or white or all or nothing teaching around cannabis in your medical training, that it's either a thing to ignore or something that's always bad. So this can make it really hard to navigate conversations with our patients. I have the summary table here. You could spend a full hour just on the evidence in this table, but this is just an overview to help kind of guide what you're thinking about in terms of our different disorders and where the current evidence stands around association with things like risk of onset, worsening of course, but also whether cannabis is useful for treatment in these conditions, which often looks like a lot different than what our other medical colleagues look at for, things like epilepsy, pain, headache, and so forth. But you can see that right now in general, usefulness for treatment is a bit mixed, overall negative. But for a lot of our conditions, some like psychotic disorders have a pretty strong association with risk of onset, but for others, it's a little bit more murky. And something I want to do to just help set kind of the frame is talk about the role of the psychiatrist. Because many of you might be like, I don't really know what to do. What if they're getting kind of a medical card from someone else? What if someone else is telling them to use cannabis? So what is my role, right? Especially if it's legal in your state. And so this is a simple framework. One, doing what we do best, diagnostic interview, so helping identify relevant psychiatric diagnoses and concerns, because again, the evidence base for our conditions looks quite different than for some other conditions. Secondly, you need to feel comfortable providing psychoeducation on the potential adverse effects of cannabis, as well as the potential therapeutic benefits. You want to feel confident in your ability to help monitor for the development of a cannabis use disorder or cannabis dependence, or whether one is persisting. And then lastly, in addition to all of that, you want to help other specialties be able to kind of assess the same evidence, because they're going to come in and say, well, for pain, it looks like this. But as you as a psychiatrist, you might be like, well, that might be true, but also they have schizophrenia, and maybe the evidence in schizophrenia for harm is greater than the evidence of benefit for pain. And then also monitoring for relevant drug-drug interactions, which I'll talk about. There are a lot of cannabinoids out there, but many of you are probably familiar with THC and CBD. These are probably the most clinically relevant right now. You'll see some other slides and from other speakers. So there's a lot of ones out there. You can go down a rabbit hole with this. But for those of you newer to this topic, I would focus on these two. THC being one of our more infamous ones, right? It's more psychoactive and kind of mentioned almost synonymously with cannabis. Then there's the other big cannabinoid, cannabidiol or CBD, which is touted very often for its health benefits, less likely and should not cause like euphoria, intoxication, but has some really interesting relationships with neurotransmitters and receptors that we like or kind of focused on, like serotonin. Endocannabinoids is another huge topic that I'm not going to do kind of service to or justice to today, but it's important for you to realize that there's an endocannabinoid system. The endogenous cannabinoids have an important role to play in things like neural development and other things, but there's a different kind of reaction between the cannabinoid receptors with the endocannabinoids versus exogenous cannabinoids, like what our patients use. That being said, I kind of highlighted below some of where the CB1 and CB2 receptors live, because this will help you understand some of the adverse effects and some of the therapeutic benefits that we'll talk about down the line. So this is just another overview table. Many of you might be used to this, right? The adverse effects of cannabis. In the short term, we expect things like impaired short-term memory, ability to learn, impaired motor coordination, altered judgment, paranoia, psychosis, euphoria, right? So this is stuff that's really intriguing and important to us as psychiatrists. Immunosuppression is another interesting one for those of us doing medically complex work. For the long-term and heavy kind of consequences or consequences related with long-term and heavy use, addiction, withdrawal, I'll talk about those today because patients often have poor understanding of that. But then a lot of the others have to do with route of use. So if you smoke it, then there's a lot of respiratory effects like chronic bronchitis. There's increasing focus on cardiac effects. We'll talk a bit about the psychosis kind of risk. Then there's things like sexual side effects. Then my third category is the adolescence, which I'll let Dr. Markley talk about in depth. So I'm just going to put forth a case that it's something in Colorado that we run into, and many of you may have experienced this as well. So we have a 40-year-old woman with unknown psychiatric and medical history. She got brought in by ambulance and admitted to medicine for altered mental status, right? Pretty common. The team initially reports fluctuating alertness, affective lability, and agitation. They consult you later for this ongoing altered mental status. And when you get there, you notice mutism, upper extremity rigidity, and you find out from nursing that she has not been eating or drinking on her own for a few days. So some of you might be already wondering or thinking about a certain disorder, right? Vital signs are notable for tachycardia, while labs reveal a urine drug screen positive for cannabis, and also mildly elevated LFTs of unknown origin. So a few things to highlight, right? Some of you, obviously, I kind of put some symptoms of delirium out there, but also of catatonia. And in case you haven't encountered or read about this, cannabis is associated with both of those states. For altered mental status and delirium, case reports range from 7 months old up to over 80 years old. Oftentimes it's unintentional exposure through kind of getting into someone else's products or baked goods or kind of overdosing when you're not used to the potency. And it kind of looks like many other forms of altered mental status and delirium. But there's another part too where especially high potency cannabis can be associated with agitation. And so this might be something to think about if you have a patient with delirium or agitation that's sort of unexplained and maybe not responding the way you would expect. Catatonia is another thing. I think a lot of us who do inpatient type of work are seeing this. We see this a lot again with high potency dabbing types of cannabis. And it looks, again, very similar. And it's been reported way back. You can see these papers from the 1980s that talked about this, especially in kind of mouse models. So when it comes to basic pharmacokinetics, again, many of you anecdotally kind of know this, right? Like, so when someone smokes cannabis, the kind of peak action, time to onset's a lot faster and also wears off kind of more quickly compared to oral ingestion of cannabinoid products. I also kind of show some of the metabolic processes when you orally ingest cannabis. Gastric degradation and first pass metabolism by the liver play a role. When you smoke it, the combustion process plays a role. But I think something to know about is many of us don't really know what to do with urine drug screens related to cannabis. And actually, where I practiced for a period of time, they kind of stopped including it on standard urine drug screens because they're like, well, everyone's using it. And we're like, well, actually, that's not true. But also, we need to know if someone's using enough to test positive or if they're testing negative despite reporting using cannabis. Something to know is that many common urine drug screens actually test a non-psychoactive metabolite called THC carboxylic acid, the concentration of which, kind of decreases much more slowly over time in blood compared to THC concentrations. And the detection window varies widely depending on frequency, duration of use, body fat content, and all of these things. So you can get a negative drug screen pretty quickly in someone who doesn't use very consistently or very heavily. For those of you in the outpatient setting, I wanted to include this slide because I think it's really important. If you're trying to think about trending or understanding someone's cannabis levels over time, getting just a plain urine quantitative test is actually going to be hard to track because there's a lot of factors that can influence that, especially things like hydration status, things like that. So what actually we do at my institution is we trend this sort of adjusted creatinine formula, which is essentially a ratio between the urine cannabinoid quant level and the creatinine using the same urine sample. So this allows you to trend something that accounts for kidney function and hydration status over time. A few notes on the left there: patients should abstain for 12 to 24 hours prior to avoid kind of artificial raising of the level. And then also, if you have a patient, right, we have all these folks on kind of things like Ozempic and stuff like that. If someone has kind of rapid or recent weight loss, you can see acute bump in levels due to the lysis of fat stores. Don't worry about reading this whole slide. I include this to kind of point out that things we don't think about include cannabis medication interactions. Our patients don't think about it, and we don't think about it, and we often don't have easy ways to check for this in the EMR. So I included a lot of things here. I kind of alluded to the first pass metabolism by the liver. So the cytochrome system matters, and unfortunately it matters for a lot of our medications, right? So cannabis also goes through this, and there's a couple interactions I highlight. One, that it generally elevates levels of other medications, and two, cannabis is synergistic when mixed with alcohol and other CNS depressants. So on its own, cannabis is not going to give you life-threatening respiratory depression, most likely at least, but it can be dangerous if someone's taking a lot of sedative hypnotics and opioids and other things like that. The other thing I want to highlight is when Epidiolex, so that's one of our only plant-based pharmaceutical cannabinoids available in the US. It's a purified plant material. When it got released, they were able to kind of, all of a sudden, we were able to test for more things, right? The metabolic pathways, drug-drug interactions. And so I highlight a few here that kind of matter to us as psychiatrists. One, when Epidiolex or cannabidiol was administered with valproic acid, it led to an increased risk for LFT elevation. I mentioned this, right? Because our patients, the case I talked about, had elevated LFTs of unknown origin. Again, I already mentioned that when combined with other CNS depressants, you may have increased somnolence. But lastly, look at the monitoring recommendations. So I don't know how many of you actually monitor LFTs in your patients using cannabis. I know we certainly don't. But cannabidiol or Epidiolex came out with actual monitoring recommendations to monitor AST, ALT, and total bili at baseline, and then again at 1, 3, and 6 months after initiation, and then again 1 month after dose changes or after the addition of medications affecting liver function. So this is an important thing to highlight and something we'll probably have to change practice around in the future. So going back to our case, a few days and a few doses of lorazepam later, our patient seems back to baseline, but reports nausea, vomiting, and decreased appetite, tremor, vivid dreams, disrupted sleep, cravings, and irritability. They also mentioned that taking hot showers helps somewhat with nausea. So those of you more familiar with cannabis are already like, all right, I see what she's kind of pointing to here. But for those of you maybe less familiar, one of the things that is pretty under-identified, I think, in inpatient medical settings is cannabis withdrawal. We all know, again, about cannabis intoxication, but many patients don't know about withdrawal, and many providers and physicians also don't really talk about it. So something we do know is that you can have withdrawal following cessation of cannabis use, but really it's following cannabis use that's been heavy and prolonged. So not the person who's used a couple times, not likely the person that uses once a week, but these are folks who use every day, use multiple times a day, or use high potency products or what we call like dabs, shatter, wax, things like that. There's also a variety of signs that can develop during this withdrawal period, such as irritability, anger or aggression, nervousness or anxiety, sleep issues, changes in appetite or weight loss, restlessness, depressed mood, and then some physical symptoms like abdominal pain, shakiness and tremors, sweating, fever, chills, or headache. The timeline is important because, again, this is really relevant in the acute, like inpatient setting. Onset's typically within 24 to 72 hours of cessation, peaks within the first week, and then can last a couple of weeks. But there appears to be sort of a post-acute withdrawal kind of picture where things like insomnia can persist for over 30 days. And this is something that's already identified fairly regularly in, again, patients who are using heavily and chronically, and even more in folks who maybe are enrolled in substance treatment programs. But again, if you talk to an average patient, they are not going to endorse withdrawal or often will not know that this is a risk. So I put this algorithm here. You can see that kind of the things you can use to treat withdrawal and use disorders depend on like things like, do you need them to have a negative drug test? Is there some sort of legal implication to a positive drug screen? What is available to you in your setting? But you can see that, at least in my setting, things like dronabinol are frequently used. Our burn unit actually prophylactically puts patients on this when they get admitted if they report pretty significant cannabis use and seem at risk for withdrawal. But you can see there's like a couple other medications. Gabapentin is a good old standby. And then things like mirtazapine, trazodone, zolpidem can help with things like the insomnia component. When it comes to cravings, things like N-acetylcysteine have some good evidence and obviously is available over the counter. But really for severe withdrawal symptoms, we often find that a sort of quote unquote replacement therapy with cannabinoids can be helpful to help with people, especially if they can't leave the hospital and resume use if that's what they plan to do. Now, the other thing I alluded to in the case, right, was the sort of nausea that gets better with showering. So for many of you, that will trigger the idea of cannabinoid hyperemesis syndrome. And so this is something we see a ton of in Colorado, and states with legalized cannabis see a lot of. And there was a significant rise in our state following legalization. But really, it looks a lot like cyclic vomiting, except it is associated with, again, heavy and chronic cannabis use. Patients sometimes do need inpatient medical hospitalization to help with symptomatic treatment. And if they get stuck in this cycle, right, because they feel more nauseous, so they use more cannabis, not realizing that that's part of why they're more nauseous. But there's a whole host of other effects, depending on which organ you're talking about. The American College of Cardiology has come out with data as recently as this year, talking about cannabis's association with sudden cardiac death, heart attacks, tachycardia, stroke, things like that. Obviously, I already talked about kind of the respiratory risk. That's mostly if you are smoking. And we talked about liver as well. And then there's this sort of question. There's some papers out there about increased risk of infection, effects on immunosuppressant levels, and increased risk of things like head and neck cancers. So again, back to our case. So now a few days and a few doses of dronabinol later, the patient's cannabis withdrawal symptoms improve. They deny hallucinations, though towards the end of the interview state, I want to leave. With further questioning, they describe feeling like she's being watched through the air vents. So now you're like, oh gosh, where did this come from? In my updates course, I kind of present more family collateral, but assume this is a patient that maybe doesn't have a history of psychosis, right? But this is something that we see a lot. So the cannabis-induced psychosis, some of my colleagues on this we'll talk about things like schizophrenia, but we know that cannabis-induced psychosis is a thing, again, more highly correlated with using high potency forms of cannabis. But basically, there can be a role, a few highlights here, there can be a role for medications if symptoms either don't improve well with cessation of cannabis use, if they are quite severe, or, also actually if the patient's not really willing to fully cut down on cannabis use. So you might be sitting there going like, well, why would I use a medication? But again, the idea here would be harm reduction, which will be one of my final points of this talk, is that we helping patients with this can help them towards maybe decreasing unsafe use of cannabis. But basically, a lot of the time, if you're treating this, we're typically starting with atypical antipsychotics. You may need to move on to adjunctive treatments if it's more refractory, and medications may be needed indefinitely if a patient continues to use cannabis. But don't forget other important things like psychosocial interventions, motivational interviewing, and things like that. We're getting near the end now, so bear with me, but a few high yield tidbits and harm reduction strategies, because I mentioned that before. One, formulations of potency. I couldn't go over a lot of this in depth, but a big thing for you to know is that high potency, so again, this dabbing, shatter, wax that I talk about, generally lacks evidence for a lot of things in efficacy and benefit, but does have a lot of evidence of harm, particularly in the psychiatric realm. Again, more associated with psychosis, self-mutilation, violence, and aggression. CBD predominant strains in general are less risky with psychiatric comorbidities, but I'm making sweeping generalizations here. The other thing to think about with your patients' use, one is again, are they using really high THC concentrates versus CBD predominant strains? But then routes of use. Are they smoking? Are they orally ingesting? Are they using it topically? Because the risk changes with all these things. So smoking and vaping are one of the biggest risk forms because you have these other health effects as well. And then lower risk, I put a little asterisk there because lower risk in terms of physical health is often a bit lower with orally ingested forms, and then definitely fairly low with topical forms. Third, frequency of use is important to think about. So again, if your patient is using more infrequently or intermittently, that is less risky than your patient who's using daily or multiple times per day. So less associated with developing use disorder or withdrawal. And so these are all things, I bring this up because what you'll hear the rest of our workshop is that you'll need to take really nuanced approaches to talking with your patients and really nuanced approaches to actually the risk-benefit analysis. So again, like I mentioned earlier, trending levels may be helpful in the outpatient setting, but you want to make sure you're using the right labs to do that. So, summary, because I know that was a whirlwind. 1, cannabis has been associated with acute neuropsychiatric effects like delirium, catatonia, agitation, and psychosis, especially in medical and other acute care settings. And so as the psychiatrist, you need to intentionally consider a lot of things, the presence of cannabis, the role of drug-drug interactions, and the role of lab monitoring, because in the case I presented, all of these things came up. Cannabis use disorder and withdrawal are often under-recognized and under-treated disorders. So you need to kind of pay more attention to this. It's very easy to kind of let this fall to the wayside compared to opioid use, methamphetamine use, but cannabis can be quite detrimental for some patients who have some types of comorbidities. And then lastly, risk-benefit discussions with cannabis are complicated and need to be tailored to individual cases, both psychiatric and medical comorbidities, and I'm hoping the rest of our workshop will help you do that. So I said I have no disclosures, which is true, but I did want to highlight, when you go through my references, you'll see a lot of things came from these, and these are nice, like, kind of compiled, essentially literature review that's done for you. I do get royalties from the book on the left, so I just want to highlight that in case you do not want to use that book. And then lastly, if you want to implement some cannabis, curricula in your institution, we have one available for free to download from the MedEd portal. And then, again, I know there's a pre-recorded session. If you have any follow-up questions, please feel free to reach out to me by email or kind of seek me out at ACLP. Next will be Dr. Lex Denysenko talking about headache and perinatal patients.
Hi, I'm Dr. Denysenko. I'm a CL psychiatrist who's also board certified in headache medicine. And today I'm going to talk about cannabinoid treatments in migraine patients who tend to be predominantly women. And so then that carries the additional perspective of people with childbearing potential. I have nothing to disclose. So in Pennsylvania, where I work, we do have a medical marijuana certification process. So a patient can come to a doctor. The doctor then decides whether or not the patient meets the criteria for medical marijuana certification. And then the patient goes and gets a medical marijuana card, after which point they can go to a dispensary. I began my first certifications in 2018, shortly after the first dispensary opened. And I performed countless medical marijuana certifications with at least 100 or maybe more who would recertify with me annually. But by July 2024, I decided to stop doing medical marijuana certifications for multiple reasons, which will become evident shortly. But one of the major ones was that I was actually kind of getting very bored doing this. When we get a patient who comes to a medical marijuana certifying provider, this is the typical kind of patient that we would get at the headache center. Someone with chronic migraine might have also some anxiety and depression symptoms. They already are maxed out on their preventives and abortives. In the case of case A, this is someone who really has done her research and has determined that she has found the right strain that works best for her headaches. She smokes and vapes 2 to 3 times a day and denies that she has any adverse effects. Please recertify. And in a case of case B, where we have someone who maybe is a little bit more anxious about whether or not she should try medical marijuana, her friends, maybe her doctors are saying you should try this, but she's actually never done medical marijuana or any marijuana, for that matter, in her life. We're going to get back to these cases later. What I developed was a script, if you will, for every single patient. And that included not just what the state wanted, which is for you to do an H&P with a lot of focus on substance use history and psychiatric history, but I also wanted to tell them the risks and benefits of medical marijuana. And I also needed to educate them on some of the basics of medical marijuana pharmacology. Including the laws in the state about how you are protected from possession of medical marijuana and how you are not protected. And then I had to explain further what were the next steps after I certified the patient. All of this took a lot of time, and it was the same script for every patient. And eventually it became something that I didn't want to do anymore. In Philadelphia, where I work, we have all of these dispensaries to choose from. Each one of the dispensaries has different products in their store. Some are proprietary for that particular franchise. Others are available across different franchises. Additional problem here is that across the river in New Jersey, where marijuana is legal for everybody, you could theoretically, although illegally, cross over the border, purchase marijuana, and bring it back. And I had no control over that. See, what I developed an understanding for was that my relationship with the patient was that more of a certifier consumer relationship rather than a doctor-patient relationship. Because while it appears to be the same sort of process in an analogous manner, It's more kind of similar to, let's say, I say, you have high blood pressure, and now you can pick which color pill you like best. The entire medical decision-making process, the part that I enjoy as a physician, was really lost. And it's the patient was then up to them to decide what they wanted to do. And I didn't like that lack of control and a sense of, um, of lack of a standardization with the kind of prescription that I would want a patient to take. One of my colleagues asked, well, why can't you just prescribe dronabinol? After all, that's identical to THC, and you can dispense it in however way you want to order it and tell the patient to use it as directed. But the problem is that medical marijuana is not THC. It is a lot of different compounds. I'm not even going to go into the specifics about all of them because we have no idea if anything on this slide is actually clinically relevant. These are just things that we have discovered about these different chemicals that are present in marijuana. Delta 8 THC on the bottom. Here's an example of how it compares to Delta 9. There's really only one difference in a double bond in the top left aromatic ring. That's actually not derived from marijuana. It's synthetically made from CBD, allowing it to skirt laws. But it has very similar, perhaps maybe weaker binding affinity than Delta 9. But these are some of the cannabinoids. And then these are the others. If you look at the difference between CBD and THC, there's not that much difference between those two compounds either. And yet we know a lot about what CBD can do, but we don't know how much of this is actually particularly important. Maybe some of the top one I listed here is of it being a negative modulator of CB1 might be the most clinically relevant, and maybe some of the other anti-inflammatory processes here, and maybe some of the serotonin agonistic properties, but we don't know. In addition to the fact that there's all these different chemicals in marijuana, cannabinoid receptors behave the way that TRPV1 vanillate receptors behave, and some other receptors as well, in that they exhibit what's called hormesis. This is a biphasic dose response. You might hear future speakers today to mention how this could be a U-shaped curve. You see this when we're talking about spices, right? Whether or not you're using capsaicin for its analgesic benefits or you're eating chili peppers because you enjoy the pleasant response, those effects only occur at high consistent dosing. But when you first use capsaicin for pain, it'll cause irritation and pain. When you first take something hot by mouth, it is not a comfortable experience. Same thing if you go into a hot tub. If you can activate a TRPV1 receptor at 42 degrees Celsius, about 107 degrees Fahrenheit, it is painful initially, but then becomes pleasant and soothing later. And it is quite possible that THC and CBD or some combination of thereof, while it's anxiolytic and antiemetic at lower, more typical doses, if you consistently do it at high doses, it'll have a pro-emetic effect. And some people think this might have something to do with cannabinoid hyperemesis syndrome in some patients. And this variability in hormesis is different between different people. So you might have someone that's sensitive to this biphasic dose response and others that are tolerant. That really makes it very hard to find the optimum dose in milligrams that one could prescribe of medical marijuana to a patient. And there's other variability of responses in individuals. And on the left, we see the individual kind of responses. There's differences in both age and sex and route of administration and the method of how you use it. And there's genetic polymorphisms as well. The CNR1 receptor polymorphism might predispose to a different experience to the cannabinoids, potentially a different risk of hyperemesis or psychosis. How you metabolize it through 3A4 or other pathways can make a difference. There might be a higher chance of addiction with your different polymorphism at COMT. And then there's this epigenetics regarding methylation and how this could have a difference in how one responds to cannabis. And then past the cannabinoids, there are the terpenoids. So terpenes are these volatile aromatic compounds that are present in fresh marijuana and kind of quickly degrade over time. And we now think that some of these are the top 5 that maybe have the most research behind them, but there's plenty others. They might have additional benefits for inflammation, for the high, the euphoria, potentially an anti-pain benefit, or maybe an anxiolytic benefit, increased neuroplasticity. We're still trying to explore all of this. And in America, where almost all products are now really high THC, if there's going to be differences between the products, it could very well be the entourage effect of these different terpenes that are actually causing more of the benefit than the ratio or total dose of THC and CBD in that product. Now, when you're doing your CME, the question that this will respond to is now going to be incorrect because we have a new study that's randomized control that I'm going to talk about in the next slide. But most of the data for migraine in cannabinoids are low quality retrospective and case reports that show that there was potentially some modest effect to medical marijuana in migraine patients. And this is something that we've actually known for centuries. But this is the first RCT regarding migraine and the use of cannabinoids. And what they found was that there was superior pain freedom at 2 hours after a migraine attack, and also sustained for the next 24 hours that was not present with either the THC alone, the CBD alone, or the placebo. And this again speaks more to that entourage effect, that the ratio and the combination and interplay between the THC providing some of the headache benefit, maybe the CBD calming down some of the potential adverse effects of the THC, and maybe providing its own anti-inflammatory benefit that is not present without the THC, could be at play here. But there are risks to use of cannabinoids in patients with migraine. First of all, patients with migraine might have a higher chance of having bipolar disorder. If you do a poll of all patients with bipolar, about a third of them have migraine. And there might be some interplay between those two disorders, including a higher risk for conversion to mood deterioration or mania if antidepressants are used without a mood stabilizer in someone with bipolar and migraine compared to the patient who does not have migraine but has bipolar. But we don't actually know if there is a higher risk of psychosis, schizophrenia, or mania when cannabinoids are used in patients with migraine. I will talk about fertility and other risks to the baby. If for migraine patients, there might be an additional risk of medication adaptation headache. This is when you use a medication as prescribed and not even at a level that one could ever consider addiction, and yet an additional constant headache can develop, worsening the complexity of your headache disease. And that might occur in migraine as well, maybe more so in the vape formulations. Some of the data on these really high quality studies was very surprising to me, because when we think about substance use psychosis, we think about the big ones, the bad ones like LSD, PCP, cocaine, right? Bath salts. But cannabinoid-induced psychosis, while it might be less risky unless you get to really high THC doses, what this then causes a higher risk of is developing a chronic severe mental illness in the next couple of years, much higher than substance use-induced psychosis from other substances. And it's particularly more risky with an odds ratio of almost 5 if you use a high potency THC. And I almost find this study to be almost quaint that in 2019, they would define a high potency THC product as greater than 10%. It's now almost commonplace that most THC is 20 to 30%. High CBD might attenuate some of the risk of positive symptoms, but the effect size is small, and it's not going to prevent you from getting a psychotic episode from a THC CBD combination. This Canadian study was also of interest to me. They really looked at how the incidence of new schizophrenia cases has increased, and how the slope changed when cannabis became medicalized and when it became fully legalized without the need of a certification. And the proportion of cases that could be attributable to a previous case of cannabinoid-induced psychosis was much higher. So moving further, there we go. There are effects in the male reproductive system regarding reduction in sperm counts, and the female reproductive system in terms of both a change in ovulation as well as placental failure. And there's prenatal effects, higher NICU rates, lower birth weight, birth defects in both the brain and the kidney systems, and a higher propensity for stillbirth. In early childhood, exposure to cannabinoids during pregnancy increases risk of emotional dysregulations and ADHD and glucose impairments. So let's go back to our cases. What can we talk about for our two cases here? Well, in case A, I thought, well, if you're actually re-vaping because you're getting a headache reemergence, maybe we should use a more balanced approach, perhaps nightly. Maybe that'll help as a preventive to reduce the need that you have for an increased abortive. In this case, though, she says her vape works the best and oral medical marijuana does nothing. So what are you going to do then? If we actually look at this product that she said worked best for her, you can see it has a very high THC and a very complex favorable terpene ratio. Will it work for anybody else? If I said to another patient, try this, my patient said this worked, I have a good chance that that patient could try it and might say, actually, I hated it. That one was terrible. It made my headaches worse. Again, speaking to the individual situation. So what should we do for case B? For many of my patients, all I could say is, why don't you start at a low potency, a 1-to-1 mixture, and then increase as tolerated. See if that preventive effect will actually have benefit before you start going to these really high potency ones. Thank you so much for taking this time. I don't have my email, but you can always email me or see me at the conference. Thank you.
Hello, my name is Dr. Laura Markley, and I am from Akron, Ohio at Akron Children's Hospital. And today I'm going to be talking about the psychological and developmental impact of cannabis exposure in children and adolescents. I have nothing to disclose. And today I want to touch upon evolving trends in youth cannabis exposure and talk about why that's problematic, because youth are very developmentally vulnerable to THC use and its effects, and to identify the developmental, psychiatric, and social sequelae that are occurring as a result. There are several physical sequelae as well, but we're not going to go into those today just because of time constraints. So why focus on children and adolescents? Adolescents represent the highest risk group for the onset of mental illness. This is a developmental period marked by both heightened vulnerability due to neurodevelopmental changes and critical opportunity due to shifting identity, more autonomy, shifting roles. Kids are also being exposed to psychoactive amounts of THC via parental use, accidental ingestion, and sometimes even recommendation for unapproved use by practitioners. And then involving social media environments and policy changes like legalization, the ability to order substances online, they're actively reshaping risk trajectories. So some basic concepts today. Typically, young adolescents tend to experiment with what they can get to in the house or in their home environment, which tends to be tobacco, alcohol, inhalants, over-the-counter substances. If you look at substances like inhalants, it tends to be more middle schoolers using it, because once they get more freedom to branch out, they're not going to be using the inhalants in the home anymore. They're going to move on to other substances. However, post-legalization, more parents are using. So now cannabis and THC products are also on that list. So not only is access improving, but the use is being normalized. early use tends to be in the context of experimenting with peers. We are hearing a lot more about the context of family use and experimenting with family members, because perceived harm is a deterrent to use. When things are legalized, even though many of the main causes of death in this country are due to legal substances and means, such as firearms, um, processed sugar, alcohol, cigarettes, there is this association of legalization and safety that is incorrect. So unfortunately, the less perceived harm, the more use. So with legalization efforts increasing on a national level, we're seeing that decreased assumption of risk and that increase in use across the board. Marketing of vaporized nicotine was geared specifically to youth in both advertisements and the products themselves, and alcohol and cannabis products have followed suit with little legal or corporate consequence. So I'm going to just give you a couple quick examples of some of the children that I would see on a semi-regular basis. First patient is a 3-year-old male brought in by ambulance after being found unresponsive after a nap. He was intubated for a Glasgow coma score of less than 8. He has no obvious sign of trauma, no injury on head CT or skeletal survey, and mom insists that all medications are secured, no one else in the house is sick, and mom insists that no one in the home uses substances. The patient is also not cared for outside of the home or in a daycare. Patient number 2 is a 16-year-old male brought in by ambulance after being found walking along the street in his underwear talking to himself. He's been administered IM ketamine due to acute agitation. He has no obvious signs of trauma, no injury on head CT. His electrolytes are normal, and his toxicology screen is positive for only THC. So let's think a little bit about why adolescents and young children are vulnerable from a brain development standpoint. The brain develops from back to front. So the brain's emotional and reward systems develop earlier and more completely than the systems responsible for judgment and self control can catch up to until the early 20s. So in your middle childhood and early adolescence, your ventral tegmental area is activating dopamine signals to activate the reward pathways. The nucleus accumbens is driving reward anticipation, pleasure seeking, motivation. The amygdala is linking emotional intensity with memories and environmental cues. So people, places, and things that go with that use, those sensations are being solidified with those associations. And your arcuate nucleus kind of regulates your internal drives, such as hunger, reward sensitivity, hormonal signaling, all of which influence your risk taking and impulsivity. In late adolescence, which we know goes into the 20s, it doesn't end at 18, your prefrontal cortex, which governs impulse control, decision making, and future planning, is then kind of getting fully lubed up and ready to go. So the way I think about it is that you have a fully functional gas pedal at age 12 that is geared up and ready to go and ready to put the pedal to the metal. And your brakes work about 50% of the time on a good day until you're in your 20s. So for adolescents, that means that you have this heightened drive for novelty, pleasure, and risk combined with an underdeveloped common sense filter. So strong emotional memories may imprint early, priming vulnerability to substance use disorders and other risky behaviors. So this is kind of that gas pedal versus brake pedal. And the other thing that happens during this development is that the drugs don't just take that fully developed posterior brain and get it pumped up and buff. They also stunt the development and negatively affect the development of those frontal lobes. So sometimes the little guy might win, but the more the use goes on, the less good the outlook is for the outcome of that fight. So there are lots of sequelae of early use and early exposure. We know it causes significant cognitive and memory deficits. it has negative effects on intellectual function, executive function, processing speed, and a lot of studies have shown a lack of recovery into adulthood, although some recent studies have shown that there may be some truth to the ability to recover function if cessation occurs and um, measures are taken to uh, work on improving those areas. Educational failure, increased school dropout. What do we do when kids get caught with things? We suspend them. What does suspending them do as far as their use? It's actually shown to increase it as well as to amplify negative mental health effects, but that's just kind of the way it works. Which leads to school failure and unemployment, relationship difficulties, domestic violence, especially with the higher concentrates. We are seeing more and more agitation and aggression. There's also an increased prevalence, as was just talked about by Dr. Denysenko, of psychotic, mood, and other addictive disorders. And so, with early onset, ongoing, persistent, high frequency, high potency, there is evidence of negative developmental outcomes. The scary thing is, as we've talked about throughout this talk, the potency, is just astronomically worse than it was 30, 40 years ago. So when I bring up this next study, um, uh, the Dunedin study, we're going to look at the fact this and the Dunedin study were both done at a time when the potency of the drugs was not what it is right now. So this slide shows that the earlier brain is exposed to a substance, the later the risk, the later greater the risk for substance use disorders. So this study showed that if you started drinking before the age of 13, you had about a 50% chance of developing a lifelong or a substance use disorder at some point in your lifetime. And it was about 20% for marijuana. Now, if you didn't have your first drink until 21, it went from almost 50% to nearly 10%, which is still not great, but a whole lot better than 1 and 2. With marijuana, it went from almost 20% to 4%, so nearly 5%. So it's quite a difference. So that delaying use even by a few years drastically reduces the chances that someone will develop a substance use disorder. So the Dunedin study is a large birth cohort that was followed for 38 years in the 1970s, 80s, 90s that really looked at cannabis-associated cognitive decline. Now, granted, when cannabis was first made illegal, it typically had about the same concentration as hemp in the 1940s, about 0.3% THC. In the 1970s, you're looking at 1 to 2% THC, the 90s 3 to 5%, early 2000s made up maybe 5 to 10%, and nowadays, even your plant product is looking at 20 to 25%, and the concentrates approach 100% THC. So these studies were done on much, much less potent materials, which is somewhat disturbing to think about. So they followed these individuals throughout their lifetime. They looked at many, many different aspects. It wasn't just drug use, but they looked at how many times people were diagnosed as having a substance use disorder. So the categories were those who never used, if they used, but they were never diagnosed as having a disorder, and then throughout the time, how many times they held positive for that diagnosis of substance use disorder. And what they found were that the youngest starters and most prolonged users throughout lifetime lost about an average of 8 IQ points, which means some less, some more. But those who had never used gained on average an IQ point. So then they set aside the heaviest users, and there was still a noted decline of a few IQ points from childhood, which was still seen in less heavy users who had started in their teens. So still the early use was problematic. And unfortunately here, again, this was one study that showed that there wasn't great recovery from those effects. So just consider that most studies point to a vulnerability of the adolescent brain, not to only functional loss, but development of long-term disorders with early exposure to substance use. And delaying exposure to substances is key to the prevention of long-term substance abuse and is or substance use disorders, and associated with less cognitive decline and better overall psychosocial functioning. Early exposure to high potency THC products is particularly concerning, and unfortunately, that's what the trend is showing, and it hasn't been long enough to know just how much worse those outcomes may be. So THC and mental health. So in acute recreational use, many of the cannabis products on the market that young people are using are those which are associated with less risk of getting caught. And most of those things are things that do not make them smell, which include things like edibles, dab pens, nectar collectors. If you want to know what any of these are, please find me at the meeting. I'll tell you all about it. But even herb contains high amounts of THC. So dabs, wax, shatter, it's highly concentrated forms of THC that are used via vaporization, and that the use of these products continues to increase population in general, but especially in adolescents. And it's been associated with rapid onset of mood and psychotic symptoms in use, even upon novel exposure. So realize that THC with large exposure in these concentrates has potential to dysregulate serotonin signaling. So higher concentration products increase risk not only of psychosis, but of affective destabilization. And some of these kids come in and it's literally like the Hulk smash. They are, people assume they're on PCP. They can be extremely aggressive, very, very strong, and can take a lot of effort to get back to baseline. And these effects can be prolonged, and they usually require acute psychiatric hospitalization and antipsychotics to stabilize them. So it's also associated with other substance use and depression. So we got away from saying marijuana is a gateway drug in the past because it wasn't clear that everybody who used marijuana was going to end up with another disorder. However, we do know that those who do use marijuana are at higher risk for many other disorders, including other substance use and major depressive episodes, suicide attempts, and deaths by suicide. So this highlights this a little old, it's from 2018, but the red bars are for no marijuana use. Blue is any past year marijuana use, even if it was just a couple times, and green is for daily or year daily or almost daily marijuana use. So you can see that unfortunately, one of the things that um, is notable on this slide is that even if you're not a daily user, there can be significant consequences for marijuana use on both your mental health and your risk for using other substances. So problem cannabis use, basically there's a symbiotic relationship between psychiatric symptoms, especially in youth, and cannabis use. So psychiatric symptoms predict problematic cannabis use, and it also predicts the perception of cannabis use as harmless or sometimes even quote unquote helpful. It's the problem cannabis use much higher in individuals with mental illness, including schizophrenia, mood, anxiety disorders, personality disorders, and PTSD. And repeated studies have shown as cannabis use worsens, so does mental illness. And as mental illness worsens, cannabis use escalates. So the common consensus, the current consensus in adolescents and children is that no evidence thus far has found any benefit for recommending marijuana for a mental health disorder in a child or adolescent that would outweigh the potential harm. So these are just a couple examples of the risk of a major depressive episode in substance use. And these bars are in blue, those patients who had a major depressive episode, and the proportion of uh, people that did not have a major depressive episode. So those in every category, those with substance use, especially marijuana, show a higher prevalence of having a major depressive episode. One could extrapolate from that it is not an effective treatment and is also not preventative in any way from a major depressive episode. Likewise, moderate to severe anxiety symptoms are much more prevalent in those who have used substances and especially marijuana or marijuana products within the last year. Cannabis and suicide risk in adolescents. So studies have consistently shown that there is either an equivocal, which is the first two studies in this slide, but predominantly positive relationship between, meaning increased risk for suicide and suicide attempts in users of cannabis who are in their adolescence. They the most recent study showed that adolescents with cannabis use disorder had roughly 40% higher odds of suicide attempt or self-harm combined with depression. The odds rose 9-fold. So looking at legalization and death by suicide rates in young people, there was a recent study in the American Academy of Child and Adolescent Psychiatry's journal, JCAP, that looked at suicide rates in youth 12 to 15 years old and compared them to rates in states where there was no legalization or legalized medical marijuana versus those with legalized recreational marijuana using National Vital Statistics System over the first 20 years of this decade. So when they looked at the unadjusted annual suicide rate, they found that states with no legalization had statistically significant less rates of death by suicide than states with medical marijuana, which had significantly lower rates than those states with recreational marijuana. Among female identifying youth compared to states with no legalization, there was a 10% increase suicide rates in states with legalized medical marijuana and 16% increase in states with legalized recreational. And across female and male identifying youth age 14 to 16, the risks were at 9 and 14% higher in contrast to youth in states with no legalization or medical marijuana, respectively. So the authors noted that these findings are consistent with existing data showing that the onset of cannabis use before 16 years of age really does have a significant impact on adolescent neurodevelopment and cognitive function. So why would we do this, right? Here's some of the THC forms that are available, the advertising that is available. Buddy, the cannabis superhero in the upper corner there, was traveling in Ohio, where I'm from. They were having a little pro-marijuana bus drive around and meet with families on the street to promote the legalization of medical marijuana before it was legalized in this state. Why do we do it? Because it's profitable. If you look at how much of a population consumes how much product, it really is about 20% of consumers that consume about 70% of the product. So how do you make a stable base? Remember this slide? Remember that if you start using marijuana at 13 or under, and really we didn't even go under with the study, but if you went less than that, one would think that the risk could be even higher. You are creating those at risk of having a substance use disorder later in life, and you're creating your stable base. So to go back to the patients I brought up initially, the 3-year-old male that was brought in after being found unresponsive after a nap, toxicology testing was positive for only THC. So mom recalled being given a free sample of gummies at a gas station recently, and she brought in the package and said they gave me these gummies, and they were Delta 8 THC gummies. And the child had gotten into the package, opened it, and consumed them. Mom had no idea. The child was able to be extubated and treated supportively until he returned to baseline mental status, but one also has to consider that we are fully aware that there are consequences to being intubated and in the ICU that may not occur until later. Patient 2, the 16-year-old male who came in, his urine THC quant showed levels of both Delta 9 and Delta 8 of greater than 5,000 nanograms per milliliter. To give you a point of reference, our tests show a positive as greater than 5 nanograms per milliliter. The mental status exam did not improve over several days on the medical floor. The medical workup was unremarkable. He was tested for multiple other potential exposures, including synthetic THC, multiple other drugs, and everything came back unremarkable and negative. He was eventually admitted to the inpatient psychiatric unit, and he was able to be discharged after 17 days on 20 milligrams of olanzapine per day. So, in conclusion, early exposure to substances leads to an increased risk for developmental stagnation and decline, substance use disorders, and acute and chronic psychological and physiological illnesses. Unfortunately, decreased risk awareness and increased accessibility to high potency cannabis and THC concentrates is on the rise, and public health initiatives and we as physicians need to focus on educating the community about these risks, and we should be confronting and correcting the public notion that substances like marijuana are a natural option for treating mental illness, especially in youth. Those are my sources, and this is my email in case anyone has any questions. Thank you so much.
Hi, I'm Helena Winston. I'm a psychiatrist at Denver Health, and I'm also an assistant professor at the University of Colorado School of Medicine. And I'll be kind of wrapping up today's presentation with a hopefully fairly quick gloss on the potential benefits of cannabis, which of course is punctuated with a question mark there at the end. I have no disclosures. So what's important here, or one of the important things, is that people perceive, a lot of people perceive cannabis use not negatively. So that means fairly positively. So when data is presented, for example, in an article that summarizes this Gallup poll, said that Americans aren't sure that cannabis is beneficial, but they're also not sure. There are a large percentage of people who've tried marijuana who actually have an overall positive view of it in terms of its effect on individual users, as well as effect on society as a whole. So whereas it's actually fairly balanced in people's opinions. So even if there's a lot known about the harms or risks of cannabis, there are a lot of people still using it, just as they do tobacco, nicotine, and alcohol. So 34.67 of adults between ages 18 and 25 years old in Colorado used cannabis in the last 30 days as of data from 2021 to 2022. And a lot of people report no issues for it. So it's important when you're evaluating data to really look at what is being argued. In particular, it's important to know, as some of the prior presenters have gone over, the difference between different compounds, especially the difference between CBD and THC, and inquire specifically about what people are using and whether they're mixed products or isolated products. Benefits are actually more likely to be tied to CBD use than cannabis use in studies, although most studies actually do not isolate CBD. The studies often mix the two or include both. You want to, of course, ask about the amount. This was discussed earlier. Higher dose or more concentrated formulations increase the risk of effects, both negative and positive. And you want to remember not to be dismissive. Many people are really seeking help for many of their health conditions or mental health conditions any way they can. And knowing the information, presenting it in a non-biased way can be really helpful for patients. So, of course, benefits of cannabis. It's a contentious issue. And by even just focusing this part of the presentation on the benefits alone and not tempering it with the risks, does that discussion minimize the risks? Just throwing it out there. It's a possibility. But there are risks, and not least of which is developing a cannabis use disorder. But there are the mental and physical adverse effects, which some of the prior presenters have gone over in part. So I did a search in wanting to present to you some of the kind of most umbrella-like data, and looking at just cannabis or THC and CBD and benefits. And this reveals quite a lot of articles, at least about 3,000. And those included case studies, series, opinions, bench work studies, as well as randomized controlled trials. So I wanted to focus on systematic reviews and meta-analyses and ask, what are those telling us about the potential benefits of cannabis? And this is by no means meant to be comprehensive. I'm going to touch on some of the potential benefits in these areas. So pain is actually probably the area, and there's a lot of overlap, of course, between pain physically and mentally, but this is the area that has possibly the most evidence for benefit. So both THC and CBD have been studied in the treatment of chronic neuropathic pain. There's a great systematic analysis performed that looked at over 38,000 articles, narrowing it down to 5 that dealt with randomized controlled trials. The risk of bias assessment was done on these studies, and 2 of the 5 had serious concerns. And the conclusions overall were that cannabinoids did decrease chronic pain compared to placebo, 33% versus 15% in a visual analog scale. And in particular, transdermal CBD decreased what was perceived as sharp pain more than placebo with minimal side effects. So that was kind of an interesting result. Another study looking at the efficacy of cannabis, and again, very generic term for pain disorder, reviewed articles and found 22 randomized controlled trials that examined the effects of different compounds listed here on this slide. 15 of those 22 showed improvement in neuropathic pain in various conditions as varied as diabetic neuropathy, multiple sclerosis, complex regional pain syndrome, and more. And the remaining 7 showed no improvement versus placebo, but did show improvements in ancillary problems like sleep and mood. This systematic review pointed out that many of the studies had small sample sizes and short time frames, and also varied in method of delivery. But interestingly, they point out that higher dose doesn't necessarily lead to increased effects. And this is something that's brought up in a bunch of the systematic reviews, that there may be a U-shaped therapeutic kind of dose response curve for THC or CBD, or since they're not often separated, we're not sure what combination or lack of combination thereof. They also point out that blinding is difficult due to the psychoactive effects of THC. The VA has actually produced a very substantial systematic review document on the benefits and harms of cannabis in chronic pain, and they conclude that low to moderate evidence that exists for the use of cannabis products in a 1-to-1 or maybe a 2-to-1 ratio that may improve pain in the short term. Another systematic review of randomized controlled trials for oral facial pain found that 5 studies were very solid. 1 showed benefit for topical CBD, again, for TMJ disorder pain, and 4 showed no benefit across multiple pain conditions. For non-cancer related pain, there was a great systematic review and meta-analysis done of 36 studies with a total of 4,000 participants. Moderate evidence supporting cannabinoids in the reduction of pain, which was greatest at 2 to 8 weeks as compared to placebo. And there was a similar systematic review and meta-analysis done a year later, including 32 studies, 29 compared medical cannabis or cannabinoids with placebo, with a follow-up of 1 to 5.5 months. It concluded that moderate to high certainty of evidence showing that non-inhaled medical cannabis or cannabinoids results in a small to very small improvement in pain relief, physical functioning, and sleep quality in those with chronic pain. So again, potentially kind of there's moderate evidence for mild improvement. There's also a Cochrane review of cannabis use for cancer-related pain. So this is where it's usually referred to as being useful. Results were looked at through January of 2023. There were 14 studies involving over 1,800 participants, looked at nabiximols plus CBD or THC alone. The conclusions were overall THC or cannabis products are not better than opioids, but that they may have some efficacy again with pain. And you can take a look at those 4 points there for the conclusions from that Cochrane review. A more recent meta-analysis of literature on cannabis and its effects in cancer patients suggests that many benefits are likely real. Interestingly, cannabis itself may have anti-carcinogenic effects as well as anti-cancer pain effects. So looking at the 1,000 or so peer-reviewed studies on medical cannabis to determine the consensus on whether the benefits outweigh the risks. The correlation strength of cannabis across all cancer-related topics indicates that support for medical cannabis is 31 points. That's supposed to be an X, 31.38 times stronger than opposition to it. It's kind of interesting. It basically reveals a significant trend suggesting support of its therapeutic potential. This analysis did point out that there are bias in the studies, and it does make the argument that regulatory changes should be made so it could be studied better. Now, moving on to away from pain to some of the other places where the benefits of cannabis have been touted. This is for insomnia as a comorbidity. Meta-analysis, this one from 2023, focuses on the utility of cannabis products for sleep. 34 studies, almost all showed some improvement of insomnia in those with medical or psychiatric comorbidities. That was with CBD alone or with 1-to-1 ratio with THC. Suggests it may be helpful for those with insomnia, comorbid with cancer, MS, mental illnesses, including PTSD or chronic pain. It's worth noting that the studies looked at in this meta-analysis were not all randomized controlled trials. Now, moving on to anxiety, there is a nice review by Roberts et al. Published this year and included RCTs, cohort, cross-sectional, and qualitative studies, a total of 57. They included evidence relating to CBD and THC, and only 13 were considered high-quality studies, and they focused on those. They did perform a risk of bias assessment and did find that there was a high risk of bias in general. Their conclusions were that 9 of the 13 high-quality studies showed an improvement in symptom reduction and/or quality of life in GAD, social anxiety disorder, and PTSD. They did point out that 3 of these 9 studies were the results were non-statistically significant. 4 of the 13 high-quality studies showed no improvement in symptoms of OCD, trichotillomania, test anxiety, or social anxiety disorder. They also point out that there's a lot of variability in dosages. So a lot of work still to be done, but possible benefit. Moving on to anxiety and sleep. Narayan et al. In 2022 looked at the use of CBD or CBD plus THC for anxiety plus sleep. The relationship between those disorders is, of course, thought to be bidirectional. And when looking at the studies, they did find that many had a moderate to high risk of bias. That said, they had 58 studies that met criteria for analysis with a total of over 5,000 subjects. And they overall felt that their review pointed out that there is evidence for an inverted U-shaped dose efficacy relationship for CBD as a sleep aid and an anxiolytic, which likely has a minimum therapeutic benefit threshold of 300 milligrams for a single treatment. So a little bit more specific conclusion drawn from that analysis that I found pretty interesting. Now, moving on to another analysis of the use of CBD THT, or the two together, for anxiety disorders. This study, from also published this year, highlighted that the data is extremely heterogeneous, and that in general, given the limited and low quality evidence, cannabinoids should not be recommended for anxiety disorders. But they wanted to point out overall the trend toward potential efficacy or benefit. So here you can see that the effect sizes are low. There are a lot of studies that cross 0 here, but overall, in this meta-analysis, there was evidence that it may help with PTSD and Tourette's disorder. And then here, it actually looks like the diamond is touching 0, but it's not. It's 0.03. So perhaps some benefit for as well in this summary. And this, of course, this is looking about looking at THC plus. This one, I'm sorry, is just CBD and CBD enriched formulations. This one is for the combination, and in combination, they showed no efficacy, no trend towards that. So in terms of psychosis, we tend to think immediately of THC as increasing the risk for psychotic disorders, and that's fairly well established that it could unmask or potentiate the risk. That said, like the question has been asked, could a cannabis product treat psychosis? And theoretically, it possibly could. And there are different mechanisms for CBD that have been hypothesized. So a systematic review and risk of bias assessment was done in 2020 that looked at experimental and observational studies, and it found that, of course, that the data was heterogeneous and that there was no evidence for improvement in cognition or general functioning and limited evidence for the treatment of the psychotic symptoms. However, it was well tolerated and had a few side effects compared with antipsychotics. Moving on to PTSD, many people with PTSD use cannabis, lifetime prevalence of 65%, current use of cannabis in that population 14%, and daily use at about 3%, many using the substance to self-medicate. Hicks and his group, their group, I'm actually not sure if that's a man or a woman, or other gender, reviewed the use of cannabis in those with PTSD. The relationship is likely, of course, still bidirectional. 45 studies looked at the relationship. There were methodological problems in general, and the conclusion indicated that they need better studies. The VA, as I mentioned earlier, produced a substantial systematic review document on the benefits and harms of cannabis. They found insufficient evidence that cannabis was helpful in those with PTSD. They found 2 observational studies comparing those using cannabis to those not using and found no difference. Here's another systematic review done in 2024, 14 studies of over 5,000 participants, dosage and route varying or not reported. Only one RCT that examined the effects of cannabis on overall PTS outcomes was included, and it showed that it was potentially promising, although preliminary, that cannabis could improve cluster B symptoms, specifically nightmares and distressing dreams, as well as cluster E symptoms like sleep. So they were the first group to kind of look at the possible use of cannabis for specific cluster symptoms. Moving on, we've got opioid withdrawal. D'Aquino and et al. In 2022 looked at cannabis and THC for opioid withdrawal, looking at observational and RCTs. There were 11 studies, over 5,000 people. They found conflicting results. 4 observational studies found an association with cannabis and improved opioid withdrawal, but 1 reported exacerbation. 4 had no association between the 2. All of these systematic reviews point out that the data is heterogeneous and that dose is important to report, as well as substance being given. Substance use disorders in general, could you use cannabis to treat them? There was a scoping review of RCTs done reviewing THC or CBD for substance use disorders. 10 studies were included, 6 had lower bias. 4 of the 6 demonstrated utility in decreasing cannabis use or improving abstinence, but they use different compounds. And there's less clear results on using cannabis products for heroin use disorder and cocaine use disorder. I'm going to gloss over this, but basically there is a fair amount of literature on multiple sclerosis and an excellent, very long Cochrane review of the efficacy of cannabis for various outcomes within MS. I've highlighted pain. It's actually, the evidence is very low and spasticity moderate. Here's more of that data and a description of high and moderate certainty. Finally, I want to just highlight this summary article from Montagner in 2024. It was a review of the literature on cannabis benefits and harms, creating an evidence map. What's really interesting with this is that the results highlight the use of various cannabis formulations, including those based on CBD, 71 distinct health outcomes were identified in the systematic review. So it's a systematic review it's a literature review of systematic reviews, and the most reported outcomes being related to various types of pain and whether the substance was safe, patient safety. So here is kind of the top part of that blown up. You can see that patients' safety and pain relief have the most studies, as well as how many studies are showing what kind of benefit. So you can take a look at that if you're interested. Finally, there's a summary article, very interesting, balancing the risks and benefits of cannabis use. It was an umbrella review of meta-analyses of randomized controlled trials and observational studies published by Solmi et al. In 2023. This was a really nuanced article reviewing various benefits and risks associated with cannabis and, quote, mixed conditions, epilepsy, chronic pain, etc. 101 meta-analyses of the safety in cannabis were included. Only those RCTs and observational studies were included. They found high and moderate convincing studies that showed increased risk of potential side effects, but they did note that CBD improved seizures, but increased other adverse events like pneumonia. Their overall recommendations are the things that we've been highlighting throughout this presentation. Children and adolescents should generally avoid, those with mental illness should avoid, those who are pregnant should avoid, and you should avoid using cannabis if you're going to drive. Finally, the American College of Physicians released their recommendations this year. They they recommend counseling people on the risks and benefits of continuing cannabis products for non-cancer pain. They advise against using cannabis in those who have SMI, current or past substance use disorders, or those who are at risk of falling or fractures due to the risk of ataxia or unsteadiness on the feet. They advise against using cannabis in those who are trying to conceive, pregnant, or breastfeeding, and the use of inhaled cannabis, that risk of inhaling a substance, for non-cancer pain. These are my references. And if you have any questions, feel free to email. Thanks so much.